Sharon Ruack, who is an assistant professor of nursing at the college and a certified midwife. In her area of practice, now that I've disorganized all my handouts, is she looks at factors that affect fetal development and mother-baby stress in pregnancy and health determinants. Let me see. Okay, and she has a particular area of interest in substance abuse disorders, and she examines the intersection of maternity forms in early life and psychological stresses and trauma across the lifespan that lead to or could be related to prenatal substance abuse. And she also evaluates and looks at the placenta function and neurobehavioral health of the fetus and the infant. So I would like to thank Dr. Ruack for speaking with us and presenting her areas of expertise. And without any more discussion, I'm handing the floor over to Dr. Ruack. Thank you.
Okay, thank you for that introduction, Dr. Kelly. Now I just got to get things to advance. Sorry about that. So I just wanted to say I've been a nurse for a very long time. I hate to share it with people. I've been a nurse since 1987 and a certified nurse midwife since 1997. And birth and maternal child health, they've always been my passion. My interest in chronic stress in pregnancy kind of arose out of an interesting group of women I cared for in private practice as a midwife, and they all practiced prenatal yoga, and it's a very long story. I wanted to do a yoga study for my dissertation, and that didn't go over very well with my chair, but anyway, here we are today. So this evening, I want to share some work with you that's led me to advocate for comprehensive psychosocial assessment during pregnancy and the postpartum period. And Dr. Kelly already went over these objectives, so I'm not going to go over them again with you guys. But I want to start by discussing behavioral health and the social determinants of health and just get a little bit of background there. The construct of behavioral health expands on mental health to include things like substance use and behaviors and habits and the wider set of forces that shape the conditions of our daily life. Unfortunately, the behavioral health status of the United States population falls well below that of other developed nations. And we have a 50% higher lifetime prevalence rate of any mental illness or substance use disorder. So one thing to note that's important is that it's universally accepted that the conditions in which an individual is born, lives, learns, works, and ages, that affects our health outcomes. And these conditions are known as the social determinants of health. And they provide a framework for assessment strategies for identification of vulnerable pregnant women. So here on this next slide, I want to talk a little bit more about social determinants of health and stress. And really importantly, in 2008, the World Health Organization stated that stress is one of the top 10 social determinants of health inequities. And to me, that's huge. On this slide, I provided for you a definition of stress that underpins my work. And this is from the seminal work of some stress researchers, Lazarus and Folkman, and it states that psychological stress is a particular relationship between the person and the environment that is appraised by the person as taxing or exceeding his or her resources. And so what we need to think about when we consider the social determinants of health is that the precipitating factors and the consequences of stress exposures, for each person, they're context specific. So that brings us back to that environment that the individual lives in. And the other thing to be cognizant of is stress clustering, which is the accumulation of multiple stressors from different sources. And this is very common for individuals who face social and economic disadvantage. And here you can see a table, and this is actually from a very recent hot off the press publication that Dr. Cavilton and I just worked on, and it's now online for Joggin. So if y'all are interested, you can go read that. But this table shows, even though we've divided them into 3 categories, they intersect and they overlap. And there's a large body of evidence that supports that these physical and social characteristics are strong predictors of adverse outcomes for moms and babies. And so what I want for you to really think about as we go through this presentation is, when we think about perinatal mental health, generally our thoughts immediately jump to postpartum depression. But what I want to highlight today is that we need to broaden that perspective if we're going to improve outcomes for women and children. We need to think about the context in which they're born and live and work. And that's critically important when we start to think about programs and interventions to improve care. How can we improve the weaknesses? And in addition to that, how can we leverage the strengths of the women and the communities that we're caring for? So before we move on to some of the data I want to share with you, I wanted to just provide some context surrounding the environment that the women in New Mexico live in. And so this map shows the census tracts in New Mexico, and this is from a report published in 2016. It's a little on the older side, but I haven't found a newer one. And this is a report of concentrated disadvantage. And it included some effects on pregnancy, but concentrated disadvantage, they defined as a measure of social well-being of a neighborhood, including the availability of services and opportunities to access care. And what this shows is that, rather alarmingly, of the 499 census tracts, almost 16% were characterized as high concentrated disadvantage, and almost 37% fell into the medium concentrated disadvantage area. So that means that over half of New Mexico's census tracts are classified as medium to high concentrated disadvantage. And this is the environment that women in New Mexico are residing in. So I just want to remind you that even though I've kind of broken these into 3 categories, there's significant overlap among the categories, indicating how complex and intertwined these risk factors are. So the first study that I want to share with you, this was conducted with my colleague Blake Borsall here in the College of Nursing, and Dr. Lisa Kakari-Stone, who is faculty in the College of Population Health and the director of the Tree Center. And in this study, we wanted to determine the associations among individual and environmental determinants of health and symptoms of what we call perinatal maternal distress. We did look at some biomarkers with this also, but I'm not going to spend a lot of time going over that. And what we did was we enrolled participants in the 3rd trimester of pregnancy, and we followed them through 6 weeks postpartum. This first slide, what it really shows you is that the demographics of the sample. And our sample was predominantly non-Latino white. They were married or partnered with some college education, and most of them had an annual income of at least $50,000. So population was a little skewed there. Only 3 participants reported that it was moderately or really hard for them, for their families to pay for basic expenses. But down here at the bottom of this, I'm just showing that mean anxiety, depression, and stress scores were higher at enrollment, and then it and then at follow-up. And 9 of the study participants met the threshold for moderate or severe anxiety, and 5 met the same criteria at follow-up. So what we found that was interesting, so this table summarizes the associations among these variables. And the first thing that I want to show is what we did to get this, what we call perinatal maternal distress, this PMD. Excuse me. And this is a composite score that we created. We summed together the scores of the scales when we assessed anxiety, depression, and perceived stress. So that is what that represents. And then time 1 is during the prenatal period, and time 2 is during the postnatal period. And importantly, having experienced emotional abuse in one's lifetime, the number of past year stressors that we assessed for, so the number of stressors that the women they reported, and the everyday discrimination score were all statistically significant predictors of perinatal maternal distress, which, remember, that was a composite score of anxiety, depression, and stress at study enrollment and at follow-up. This is just a model that we tested, and what I wanted to point out with this was that even when we controlled for stressors in the woman's life that she reported, everyday discrimination scale or everyday discrimination still strongly predicted maternal distress in the 3rd trimester of pregnancy. So the take-home message from this is that our findings supported a model in which the cumulative load of stressors was associated with adverse downstream mental health. And so that suggests that we need to make a move to a more multi-symptom or multi-risk factor assessment to improve outcomes. So I'm going to try and keep bringing home that message of moving away from assessing for depression and looking at these other risk factors. So now just moving on to a few more things about life circumstances. And again, these models that I keep putting up here, you can see how things overlap. This study was one of the first works that I did that really brought home this message to me. And this was a secondary analysis of data from one of my mentors' R01 grants when I was in my PhD program. And the purpose of the study, we tested a model that looked at associations among pre-pregnancy BMI, some 3rd trimester biological markers, and then some behavioral variables, which were symptoms of depression and perceived stress. And we looked at how they were associated with symptoms of depression. And what we found was that perceived stress, as well as screening for depression, were strongly correlated with symptoms of depression in the postpartum period. And if you look at these numbers, they're pretty close, but perceived stress is just a little bit higher or a stronger correlation. So again, it's bringing home that concept of what do women perceive in their environment as stressful, and how does that impact their emotional health. Now this, again, is another study that I conducted with Blake Borsall, and at that time, Dr. Flores Montoya was a PhD student. And what we did in this study was, again, we were looking at psychosocial risk factors and how were they predictors of postpartum depression. But in this study, we also looked at, were any preventative services associated with decreased reports of symptoms of postpartum depression? So what we did here was, this was a secondary analysis of data from the 2012-2013 Pregnancy Risk Assessment Monitoring System, affectionately known as PRAMS. And the PRAMS is a national sample, and it's data from over 41 states. And in this particular study, we had more than 30,000 available cases to work with. So in this study, we looked at the stressors that women experience. And what this slide shows you is the stressors that the PRAMS survey asks about. So some of them are pretty common. Close family members sick, they got separated or divorced, their husband lost a job, they moved. So our findings were that of the women who completed this survey, 30% who experienced 3 to 5 stressors and 42% who experienced 6 or more stressors reported symptoms of postpartum depression. So again, I'm bringing home that message of examining past stressors and present stressors and what their effect is on perinatal outcomes. And how do we go as providers, how do we go about assessing women for those? The other interesting thing in the study is what we did was we stratified women who completed the survey by likelihood of receiving a home visit to help prepare for the birth. Now, the interesting thing is that's all we know, is that they received a home visit. We don't know who made the home visit. We don't know if it was a nurse. We don't know if it was a community health care worker. We also don't know what happened during the home visit. So I think that's interesting. But when we stratified these women, demographically, the women who were most likely to receive a visit to help prepare for birth were, they were much younger. They were more likely to be younger than 20 years of age, non-white or Hispanic, low income, and unmarried. And for this group of women who were most likely to receive this home visit, the rates of physical abuse and extremely high stress burden, so that was 6 or more of the stressors that you saw on that previous slide, they were also, they were much more likely to receive a home visit. So what was important here is that the women who were in this group who were most likely to receive a home visit to help prepare for a baby during pregnancy and who actually received that home visit showed nearly 40% lower odds of experiencing significant postpartum depression symptoms than women who were also in the group to most likely to receive a home visit, but did not receive that home visit. So I found that really interesting in bringing home that assessing the importance of social support and then leveraging resources we might have in the community to provide that support. And again, we don't know what this home visit included or who made it, but the fact that they received it in this large sample of women made a difference. So now I'm going to move on to some more preliminary results. And this comes from the Enrich cohort. And what I have here is a picture of our team, because these data that I'm going to share with you would not be possible without everyone who's on this slide. And our principal investigator, Dr. Ludmila Bakareva, who is faculty in the College of Nursing. So I just wanted to acknowledge everyone on that team because this is very much a team effort. So the goal of the Enrich study is to examine the relationship between prenatal alcohol exposure and prenatal stress and how that affects some biological measures of HPA axis function and measures of stress reactivity in infants. And it's a prospective cohort of maternal infant dyads. And there are 4 comprehensive assessments that occur during pregnancy. And women are recruited into 2 study groups. So we have a healthy control group and a prenatal alcohol exposed group. So some background about this particular study that I'm going to share with you. or preliminary analysis really, is that prenatal alcohol exposure and prenatal stress affect fetal programming of the HPA axis. And then there's some statistics here about prevalence of fetal alcohol spectrum disorder. And then again, looking at these social determinants of health, like socioeconomic factors and social support, and how those are modifiers of the effect of prenatal stress. So the data, as I said, come from the Enrich2 study. And the data for this particular study are from the first 3 study visits, which occurred. The visit 1 is in the 2nd trimester, visit 2 is in the 3rd trimester, and then visit 3 is in during hospitalization for delivery. We have a fairly comprehensive battery of measures of maternal psychosocial stress that include perceived stress, adverse childhood experiences, symptoms of PTSD, anxiety, depression, and social support. And then the way that we measure alcohol intake is very comprehensive also. It's self-report using what we call timeline follow-back calendars, which are 30-day calendars that capture self-report of the individual's alcohol intake. And on top of that, we also have a comprehensive panel of ethanol biomarkers that we use. So this first table shows us that in the sociodemographic characteristics, looking at the participants grouped by no prenatal alcohol exposure, so healthy controls, or prenatal alcohol exposure, it simply shows us that the groups only differed on the average amount of alcohol that they consumed. In this next table, we have women grouped by maternal I'm sorry, they're still grouped by prenatal alcohol exposure versus no prenatal alcohol exposure. And we're looking at measures of maternal psychosocial stress. And as you would expect, what we can see is that the participants in the prenatal alcohol exposure group have significantly higher scores on measures of stress, anxiety, depression, and symptoms of PTSD. Here, women are grouped differently, and we have them grouped between single or separated, or married and cohabitating. So we're getting to that effect of their support system. And what we see is that in the group of women who are single, they have significantly higher symptoms of stress, anxiety, and PTSD. They reported a higher number of adverse childhood events and unplanned pregnancies. And then this final table shows women in this cohort grouped by lower social support or higher social support. And again, you can see that the participants in the group with lower social support had significantly higher levels of stress, anxiety, depression, and PTSD symptoms. And again, they reported a higher number of adverse childhood experiences and rates of unplanned pregnancy. So the conclusions from that, again, it makes sense that there's a higher propensity for stress and anxiety and depression and PTSD among women who consume alcohol. But we also see that the social support seems to exert a protective effect. And then I have just a little bit more to share with you. How am I doing on time? Okay, I'm going to skip this. This is some background from when we looked at prenatal alcohol exposure, maternal stress, and then we also looked at infant behavioral reactivity and regulation. So these data are from the same cohort. So we have the same measures of maternal psychosocial stress and the same measures of alcohol, But what is introduced into this study is we conduct a comprehensive measure of infant neurobehavioral function. It's called the NICU Network Neurobehavioral Scale. We abbreviate that as the ENDS, and we complete that during the hospitalization for birth. And so just really quickly, because there's another study I want to get to, this is a summary again of the participant characteristics, and you can see the only difference here is how much alcohol they consumed between the two groups. And then on this kind of complicated slide, and I apologize for that, what it shows us is that social determinants of maternal health may be transmitted to the infant. And this table suggests, and I say suggests because this is a small sample, that maternal exposure to adverse childhood experiences, which is in this column, may be associated with changes in infant tone and poorer quality of movement. And then in this table, we show that prenatal alcohol use is associated with significant differences in infant arousal and reflexes when compared to infants of moms who don't consume alcohol. So conclusions here, I already kind of went over, and these results are limited by small sample size, but now that we're emerging out of COVID and we have implemented COVID safe practices in our study, our numbers are significantly increasing in this cohort, and we'll be able to go back and reanalyze some of these data and see if our trends are still holding true. So just to bring this to conclusion, because I'm kind of running out of time, I want to highlight that the past risk factors and present risk factors are critically important and highlight that need for a comprehensive assessment. And the last study that I want to share with you is a small pilot study that was funded by our CTSC, in which I used a tool called the Antenatal Risk Questionnaire to assess for psychosocial risk factors. And the Antenatal Risk Questionnaire was developed by Marie-Paul Austin, and she is in Australia. And what this tool does is that it screens for past mental health history, past history of physical, sexual, or emotional abuse, current level of support. It asks about the mom's relationship with her mother and partner. It screens for anxiety and stressors in the last year. And in Australia, there's a program called Beyond Blue, in which they have an algorithm that they use this tool, which the last time I had an email conversation with Dr. Austin, this tool was being tweaked a little bit to add a few more things, but they use this in conjunction with the EPDS to screen for psychosocial risk in pregnancy. And they have a fabulous algorithm of then how to refer to services. But here in New Mexico, what I wanted to highlight from this was the findings from this small study was that the score on the antenatal risk scale was a significant predictor of postpartum depression. And the EPDS and the perceived stress scale were not significant predictors. So this scale is short. I think it's like 20-ish questions. I chose this scale because in a study by Dr. Austin and her colleagues, the scale was found to be acceptable not only to the midwives who were caring for the patients, but also for the participants. So again, you can see that it's that comprehensive social determinants of health that we really need to expand on and collect more data and assess the women and the families we care for by using a more comprehensive framework. This is our social determinants framework, our little diagram here that Dr. Cavilton and I had in our publication, and I have to credit Dr. Cavilton for putting this one together. But again, I've shared data with you that my colleagues and I have collected, and it demonstrates the collective effect of maternal past and current risk factors on maternal health outcomes and the possible transmission of those exposures to their infants. And so I hope that sharing this with you can help you to see how we need to move beyond the screening for perinatal depression to begin to include these factors, and then in collaboration with community to build the resources to support women who are experiencing these risk factors. So one last thing before we get to questions, I have to acknowledge the certified nurse midwives at the University of New Mexico Hospital for their overwhelming support for 2 or 3 studies that I shared with you. It wouldn't have been possible without them. So I have to just put my hand up and say thank you very much to them for their continued support. And now, if anybody has any questions. Marlena, should I unshare the screen?
Yes, if you don't mind, that would be wonderful.
I might have made it in 30 minutes.
No, you did fantastic. You did fantastic. So for those of you who don't know me, my name is Marlena, and I am the Director of Alumni Relations for the College of Nursing. And we are at the question and answer portion of Dr. Ruak's presentation. So if you have a question for her, please put it in the chat, or you can virtually raise your hand with the reaction buttons at the bottom of the screen. And we'll start taking questions. No questions for Dr. Ruak at all?
Sharon, this is Pat. I was wondering if you're not a midwife, but you're a family nurse practitioner or an adult health nurse practitioner, and you're seeing or assessing people in the clinic, what would be a good framework or a reference for a family nurse practitioner to look at to improve his or her practice when you're giving well women's health in prenatal, pre-pregnancy counseling prior to conception?
So I would recommend you probably could use the antenatal risk questionnaire, but there are, and I have to apologize because I'm blanking on the 2 frameworks that we cited in our recent publication. I have a total blank to those 2.
That's
and
okay.
I can, but
Send
there's also,
to me.
yeah, there's also 2 other tools that are not focused for the perinatal population. It's more for family practice focus. So there's a couple tools out there that could be implemented in screening.
Okay, that's a good point. That'll be good to include in, repertoires for family nurse practitioner. Thank you very much.
Mary, did you have a question? Go ahead.
Yes, thank you. And I'm having trouble phrasing it. But it occurred to me that so many of my patients definitely have had adverse childhood events, but they may not be able to talk about them, and in some cases may not be remembering them, or how that happens. They may have just put them aside. And I'm wondering, so how could you allow for that?
That's a really good question. I'm not, you can screen for adverse childhood experiences, and most individuals are okay with that form. If they repress those memories, it may come out in other screenings where then you would make a referral. I'm not a mental health care provider, so I can screen and I can make referrals. So the only way that I could see that coming out is if you screened for, say, anxiety or depression, and then you referred to someone else who has counseling and that background, who would be able to further dig into that that happening. That's the only thing that I can think about as far as that.
Thank you.
We do have a couple of questions in the chat. Do you share your results with the home visiting programs like Firstborn that visit prenatally and after birth? It seems using the right questionnaires could identify women at risk better.
I had not specifically sought out those home visiting programs, but if anybody is interested, I'm happy to share. I mean, the study is published, but I'm also happy to speak with anybody who would be interested in hearing about this.
And then, do you have ideas about matching clients with certain patterns of social determinants of health to particular community services? I was particularly interested in how well the home visiting worked for that targeted group.
I'm not sure what you're asking about matching them, but what I will say is that in the work that I've done with this and the reading and the research, it's critical if you're going to, obviously, if you're going to screen women, you need to try, obviously, to have resources to refer them to. The important piece is that's when the community collaboration comes in defining what are the needs of the women and families you're caring for, and then what resources are available in the community. So ideally, you would develop a screening process and a referral process with all of the stakeholders present, and not just myself saying, well, you should screen for A, B, C, and D, and then refer them to this. It's really, as I said in the beginning, it's the context of the women and where they live and work. So an urban hospital context may be very different than a rural context. And so it's having all the stakeholders at the table to put the program together. Does that answer the question? If not, let me, thank you.
I think it does, yeah. Do we have any additional questions for Dr. Rurak? Okay, I think we're good there. Oh, I do have one more. Leah, do you want to go ahead? Or Lee, I think I said your name wrong. I apologize.
No worries, it's Lee. And I'll just ask quickly, and I apologize for the rudimentary nature of my question. I'm just a nursing student, so I'm curious. Never say that. I'm curious as to how well these clinical environments are set up for that type of collaboration. Are there pathways that exist that it's not then pushed onto the patient to have to reach out to various offices? Like, how smooth is the referral process in some of that kind of interdisciplinary action that you were referring to?
So I have to clarify that with, I am not currently in active practice, so I don't necessarily have experience with the referral systems here in UNM. I can tell you that when I was in practice and in approaching this from research, a lot of the questions that I get are, why should we screen for this when we don't have anywhere to refer patients? In my own private practice in Colorado Springs, it was very difficult for me to find resources to send women to. Now, that said, I cannot speak, say, for the midwifery clinics or the OBGYN clinics at UNMH, because I'm not familiar with what they have for their referral system. So I would say it's dependent on each system, and it might be a little bit different for where you are receiving care.
Thank you.
Do we have another question? Go ahead, Mary.
I have a question because it even affected my question, and then this question that just occurred. And while I was listening to the whole presentation, that even if a patient doesn't receive good follow-up care, it seems to me from what I've read and also experienced, and I worked hard by myself in a rural area in TRC. And if a person if someone is even just interested in them, if their healthcare provider is even willing to bring up and ask these things and show that caring, even if there isn't a real formal follow-up system, and goodness knows everybody needs so much help. I mean, it's just amazing, this study. I mean, yeah, there's just so many people that need help. But just that caring, just that questioning and showing that this is important and that the provider thinks it's important, I think that's really vital.
I would agree with you, and I can't quote you any, study groups that have studied this, but I know that there's some literature out there of where that's been studied. So absolutely, thank you for that. Yeah.
I think we have time for one more question if someone has one out there. I believe that's everything. Thank you, Dr. Repp. We appreciate your presentation and sharing your expertise with us.
Thank you, everyone.
Back again. I just want to say thank you for your continued attention and participation. I would like to introduce our second speaker this evening. Her name is Dr. Katie Cavilton. She is also an assistant professor and a certified nurse midwife at the College of Nursing. And her research interests focus on how clinical and physiological processes during prenatal period can influence lactation outcomes. Her current work focuses on the impact of synthetic oxytocin exposure during labor on lactation initiation and duration. She has been funded to investigate the mechanisms by which oxytocin and its receptors might influence early milk production. Her program of research will extend to populations at risk. That's her future plan, populations at risk for premature breastfeeding cessation. So she has fancy words here, early lactation cessation, but basically she wants to help prevent people from not maintaining breastfeeding. Since 2014, Dr. Cavilton has practiced as a certified nurse midwife with the University Midwifery Associates at the UNM Department of OB/GYN, working with families in our local community. I'd like to turn the presentation over now to Dr. Cavilton.
Thank you, Dr. Kelly. I'm just going to share my slides. So I am so pleased to be here with you today to talk about perinatal care practices and lactation outcomes. And I would like to start by saying that in recognition of the gender diverse communities that we serve, I will be using a variety of terms to describe human milk feeding throughout this presentation. Sorry, just want to make sure the that the mute is off. 1 second. Okay. So yes, you'll hear me using diverse terms to describe human milk feeding during this presentation. So I want to start by giving my many thanks to those who made this research possible. As you can see, I've been fortunate to work with several wonderful research collaborators and also co-authors on these studies. And I want to give my special thanks and acknowledgement to the UNM midwives and the UNM hospital labor and delivery nursing team for their assistance as well, and for their wonderful care. So I'm going to start by talking about the benefits of breastfeeding. And it's been well established that human milk is the ideal first food, and it has proven benefits for both the mother or the lactating parent and the child. So infants who are fed human milk have been shown to have reduced risk of infectious disease, and this includes otitis media, lower respiratory tract infections, and also infections of the GI tract, such as necrotizing enterocolitis. They're also at lower risk for developing allergic disease like asthma, atopic dermatitis, and eczema. They are less likely to experience non-infectious GI disease such as celiac disease and inflammatory bowel disease. They have a lower lifetime risk of obesity and diabetes, and they're also at lower risk for child abuse and neglect. Lactating parents also have reduced risk associated with human milk feeding. They are less likely to experience large postpartum blood loss, and they are more likely to have a rapid uterine involution. They're less likely to have postpartum depression. And those that were not diagnosed with gestational diabetes have a lower lifetime risk of both type 2 diabetes. And everybody who feeds human milk also has a lower risk of cardiovascular disease and its associated risk factors, hypertension and hyperlipidemia. And there's also a lower lifetime risk of breast and ovarian cancer. So because of all these benefits, both national and international organizations have made recommendations regarding the feeding of human milk. The American Academy of Pediatrics recommends exclusive human milk feeding or breastfeeding for the first 6 months of life. They then recommend continued human milk or breastfeeding with complementary foods for at least the first year. They also recommend that this may continue as long as it is mutually desired by both the parent and the infant. The World Health Organization recommends initiation of human milk or breastfeeding within the first hour of birth. They also recommend exclusive human milk or breastfeeding for the first 6 months. And they additionally recommend feeding the infant on demand and avoiding artificial nipples if possible. They could go on to continue recommending human milk feeding with complementary foods for the first 2 years of life or beyond. So our governmental organizations have set both objectives and benchmarks for lactation in the United States, and they also put out reports on trends. The CDC every 2 years puts out the breastfeeding report card. And in this report card, they report on the percent of babies who've ever been breastfed. They report on any breastfeeding at 6 months and 12 months. They report on exclusive breastfeeding at 3 months and 6 months. And then they report on formula feeding of breastfed infants at less than 2 days of age. And I just want to emphasize that infants who are planned to be fed formula are not included in that statistic. And you can see that New Mexico is mostly on par with the rest of the United States in these statistics, but it is performing slightly better on any breastfeeding at 12 months and at avoiding formula supplementation during the first 2 days of life. Healthy People 2030 is a set of data-driven objectives that set the health priorities for the nation for the coming decade. And these objectives are set by the Office of Disease Prevention and Health Promotion in the U.S. Department of Health and Human Services. And they have set 2 lactation goals for the next decade. The first is to increase the proportion of infants who are fed human milk exclusively through 6 months of age. And the target for this is 42.4%. And as you can see here, we are somewhat falling short of this, with the average being about 25.6% in the United States right now. They also gave us the goal of increasing the proportion of infants who are fed human milk at 1 year to 54.1%. And as you can see, neither in the United States nor in New Mexico have we quite reached that goal either. So one point I really want to emphasize in today's presentation is that healthcare practices in the perinatal period can really set the stage for lactation success. And so I'm going to start by talking about the Baby-Friendly Hospital Initiative. And this was established in 1991 by the World Health Organization and the United Nations Children's Emergency Fund. Hospitals can be designated internationally as baby-friendly after they do two things. One, implementation of the International Code of Marketing of Breast Milk Substitutes, and also implementation of the 10 steps to successful breastfeeding. In order to be in compliance with the international code, hospitals must pay fair market value for human milk substitutes. So they may not receive free or low-cost infant formula, and they may also not give free formula samples to their clients. Another piece of this is that they must not promote any items that will discourage breastfeeding, and they can't have advertising on the hospital premises for human milk substitutes. So for example, all those parenting magazines that are often in waiting rooms, they often have multiple ads for human milk substitutes. And so items like that cannot be located on the premises. I apologize, my slides stopped progressing, so 1 second. Okay. So these are the 10 steps to successful breastfeeding. And in addition to being in compliance with the international code, hospitals also have to have a written infant feeding policy that is routinely communicated to all staff and patients. And this also includes establishing ongoing monitoring and data management systems to track lactation outcomes for that facility. Step 2 is to encourage that staff have sufficient knowledge and competence and skills to support breastfeeding. Step 3 is to discuss the importance and management of breastfeeding with pregnant women and their families. Step 4, they should facilitate immediate and uninterrupted skin-to-skin contact and support mothers to initiate breastfeeding as soon as possible after birth. Step 5, they should support mothers to initiate and maintain breastfeeding and manage common difficulties. Step 6, do not provide breastfed newborns with any food or fluids other than breast milk unless medically indicated. Step 7, enable mothers and their infants to remain together and to practice rooming in 24 hours a day. Step 8, support mothers to recognize and respond to their infants' cues for feeding. Step 9, counsel mothers on the use and risks of feeding bottles, artificial nipples, and pacifiers. And I want to highlight that this one has evolved over the recent years. It used to be, it recommended against using either artificial nipples or pacifiers in the inpatient setting. But as our understanding of the potential benefits of pacifiers for some neonates has evolved, this step has evolved as well. And then step 10, coordinate discharge so that parents and their infants have timely access to ongoing support and care. So now I want to focus a little bit on the evidence in support of the Baby-Friendly Hospital Initiative. And the first study on this was the Promotion of Breastfeeding Intervention Trial, or PROVIT. And it is a landmark randomized controlled trial of the Baby-Friendly Hospital Initiative, which was conducted in Belarus. In hospitals that were randomized to the Baby-Friendly Hospital Initiative intervention, they found higher rates of both any and exclusive breastfeeding at 3 and 6 months. They also found higher rates of any breastfeeding at 12 months. But the research didn't stop there. We actually have quite a bit of research on the benefits of the Baby-Friendly Hospital Initiative package of interventions, and these were summarized most recently in a systematic review by Perez Escamilla in 2016. And what they reported was that there is global evidence that supports that the 10 steps positively impact both short and long-term human milk feeding outcomes. But relatively fewer of these studies have been done in the United States, and most of these are observational. Global evidence may actually have limited validity in the United States, given differences in culture and also the structure of our healthcare system. And we also have a relatively inadequate understanding of how the Baby Friendly Hospital Initiative performs in rural and diverse areas of our country. There is evidence for overall the package of interventions is very effective, but there's also evidence for a dose-response relationship between 10-step exposure and lactation outcomes. So those individuals who get the benefit of all the steps are much more likely to have lactation success as compared to those who receive very few. Now, this data is mostly based on self-report and survey level data, and so there is a little bit of risk of recall bias. So in order to address these gaps in the literature and to better understand the impact of the Baby Friendly Hospital Initiative implementation on short-term lactation outcomes, we undertook this study at UNM Hospital to see how this impacts our local community. And this data was recently published in Birth in 2020. So we had two aims. The first was to evaluate the impact of the Baby Friendly Hospital Initiative implementation on short-term duration of both any and exclusive human milk feeding. And our second aim was to examine the impact of individual and cumulative exposure to the inpatient 10 steps. So that's steps 4 through 9 on short-term duration of any and exclusive human milk feeding. So this was a quasi-experimental retrospective cohort study, and it focused on the transition to baby-friendly status at UNM Hospital. So UNM Hospital began its journey to baby-friendly designation in 2010. And with this, actual implementation of the 10 steps began after May of 2011. And so during the early portion of implementation, steps are sort of gradually phased into practice. But by 2013, the majority of patients at UNM Hospital were benefiting from all of the 10 steps, and we officially received designation in October of 2014. So congratulations to our hospital. So we have two cohorts in the study. The first cohort, and both cohorts were drawn from the UNM Midwives Benchmarking Database. So these are all patients of the UNM Midwifery Service at UNM. Our pre-Baby Friendly Hospital Initiative cohort was drawn from years 2009 to 2010, and we had 449 dyads. And our post-implementation cohort was from 2013 to 2014 with a total of 555 dyads. We excluded 2011 and 2012 due to the gradual integration of practices at that time. So these were the inclusion criteria for the study. All of our participants had to be attended by a midwife, singleton gestation, so just one baby, no twins. They were all term gestations greater than 37 weeks. They all had to have a spontaneous vaginal birth. And so there were no instrumental deliveries or cesarean sections. And they all had to attend a 2 to 8 week postpartum visit. So we drew the data from 3 different sources. The first was the UNM Midwives Benchmarking Database. The second was Centricity Perinatal, which was our labor and delivery specific electronic medical record at the time. And then we also drew records from PowerChart, which is our hospital-wide electronic medical record system. We did logistic regression models to predict short-term breastfeeding duration from inpatient perinatal care practices. And so this is the key demographics for our study. They were largely stable across both cohorts, as you can see. The people of color made up approximately 2/3 of our sample, and the majority were of Hispanic ethnicity. Maternal age and gestational age, as you can see here, both increased very slightly from the pre to post baby-friendly cohort, and both NICU admission and maternal complications increased during this period. And we think this may be due to some shifts in practice that were occurring at this time. So as a reminder, our first aim was to evaluate the overall impact of the implementation of the Baby-Friendly Hospital Initiative on short-term lactation outcomes in our patient population. And we did find that implementation increased the odds of any human milk feeding at 2 to 8 weeks postpartum by 65%, and the odds of exclusive human milk feeding by 43% among midwifery patients at UNM Hospital. And so this was a very effective intervention for our patients. Our second aim focuses on exposure to individual steps and cumulative exposure to the 10 steps on the short-term lactation outcomes. And so this next aim focuses only on the post-baby-friendly cohort because that's where we had good documentation of their exposure. As you can see, the inpatient steps were experienced by the majority of the clients in the sample. 87% received immediate skin-to-skin contact and or initiated breastfeeding within the first hour of life. 89% of our couplets were rooming in and had no separation during the hospital stay. And greater than 92% received the remaining steps, which all focused on breastfeeding education, support, and avoidance of artificial nipples or formula supplementation unless medically necessary. Each additional exposure to one of the inpatient 10 steps increased the odds of any breastfeeding by 81%, and the odds of exclusive human milk feeding by 70%. So each additional step they received increased their odds they would still be breastfeeding at their postpartum visit. We also found that for each of our lactation outcomes, there was a single step that proved to be a particularly powerful predictor. And so step 9, avoidance of artificial nipples or pacifiers, increased the odds of any human milk feeding by 5.7 times. And step 6, or avoidance of formula unless medically indicated, increased the odds of exclusive human milk feeding by 4.4 times. So they were quite powerful interventions. So take-home messages. The Baby-Friendly Hospital Initiative improved lactation outcomes in our local community. And following successful implementation, both any and exclusive breastfeeding increased 11% at 2 to 8 weeks postpartum. Consistent with the literature, this study demonstrated a dose-response relationship between exposure to the 10 steps and short-term duration of any and exclusive breastfeeding. And to our knowledge, this is the first study to really look at this using objective clinical documentation rather than self-reported survey data. Avoiding formula supplementation and exposure to artificial nipples had the greatest effect on lactation outcomes in our study. And we think this may be because it has the potential to disrupt the natural balance between supply and demand, which can really impact on milk production. And this study was strengthened by its quasi-experimental design and collection of objective clinical data. It was limited by the fact that it was retrospective chart review. And also there is some potential for selection bias. So we did only include dyads that had a postpartum visit, so it may not speak to patterns among those that did not attend that visit. So we talked a little bit about how healthcare professionals can adjust their inpatient practices following birth and how that can set up clients for success with breastfeeding. But can practices during labor and birth itself also influence our lactation outcomes? So that was my next question. And so the next study focuses on the relationship between synthetic oxytocin exposure in labor and lactation outcomes. So synthetic oxytocin is a life-saving medication, and it's used for induction or augmentation of labor and the prevention and treatment of postpartum hemorrhage. It's really quite widely used. In the Listening to Mothers 3 survey, which is a nationally representative survey of childbearing experiences, approximately 50% of the participants received synthetic oxytocin for labor induction or augmentation. It's also used in the majority of childbearing people for the prevention of postpartum hemorrhage. Oxytocin is also known to be a key hormone for lactation, and it's released in response to nipple stimulation and then binds to its receptor on myoepithelial cells in the breast or chest. And this induces them to contract and then release stored milk. There are multiple physiological means by which we think synthetic oxytocin might affect this process. So, and they have to do with being exposed to levels of oxytocin that are higher than one would sort of naturally experience in labor. We think that those very high levels of synthetic oxytocin might desensitize receptors in the mammary tissue. And we know this happens in uterine tissue, which is why the body becomes less responsive to higher and higher doses of oxytocin in labor. We think it may also be happening in the breast. We think it may also have the potential to disrupt feedback mechanisms to the brain, so that when the nipple is stimulated, the brain might release different levels of oxytocin or prolactin. Prolactin is really important for milk production. So if those levels are different, you might see a different result as far as milk supply goes. And then we think the neonate may also be exposed to it during labor through the placenta. And this could influence neonatal feeding behaviors. There is some evidence that among newborns that were exposed to oxytocin for induction of labor, that they're much less likely to feed within the first hour, and they show much fewer pre-feeding behaviors. So let's talk a little bit about synthetic oxytocin and lactation. So there's quite mixed evidence in the literature regarding the relationship between oxytocin dose and exposure and human milk feeding. Some studies show a negative effect of oxytocin on lactation. Others show no effect, but to my knowledge, no studies have shown a positive effect. Most studies focus on whether or not clients receive oxytocin or not during labor. It's a sort of a yes/no question. Fewer focus on the duration of exposure or the total dose of oxytocin exposure. And so there are calls in the literature for more work in that area. There's limited evidence of the use of synthetic oxytocin for active management of the third stage. So this is given to prevent postpartum hemorrhage, but there is some evidence that it can lead to earlier cessation of breastfeeding. And also, birthing in a baby-friendly hospital might weaken the association between synthetic oxytocin and lactation outcomes. In a study by Dozier and colleagues, laboring people who were exposed to IV oxytocin in a non-baby-friendly facility were more likely to experience early breastfeeding cessation. But the same was not true in the same study for those who birthed in a baby-friendly facility. So, two aims for this study were to examine the association between synthetic oxytocin exposure during labor and short-term lactation outcomes, and also to determine if this association was influenced by implementation of the baby-friendly hospital initiative. So the data for this study is also drawn from the same retrospective cohort sample that I described in study 1. And we extended our chart review to look at total oxytocin dose received during labor, so that's stages 1, 2, and 3 of labor, and also the total time of oxytocin exposure for those receiving it for induction or augmentation. We had a total of 991 pairs in this study that met inclusion criteria and also had documented oxytocin dosing information. And so our pre-baby-friendly cohort included 457, and our post-baby-friendly cohort included 534. So the key demographics remained stable across both cohorts, and there were no differences between these two cohorts for use of epidural anesthesia, IV sedation, or exposure to oxytocin during stages 1 and 2 of labor for augmentation or induction. And on the bottom of the slide, on the left, I have oxytocin dose during stages 1 and 2, and on the right, I have oxytocin dose during stage 3. And for those of you who need a refresher, stage 1 of labor goes from the onset of regular painful contractions to full dilation at 10 centimeters. Stage 2 goes from full dilation to the birth of the baby. And stage 3 lasts from birth of the baby to the birth of the placenta. So the majority of our participants, 60%, did not receive synthetic oxytocin during stage 1 or 2 of labor. The remaining 40% who did receive it for induction or augmentation received a median of 2.56 units, so not milliunits, but units, during labor with a range from 0.01 to 40 units. The majority of our clients received IV oxytocin for third stage management to prevent hemorrhage or treat hemorrhage with a median of 18 units. And approximately 5% of these received no oxytocin at all. So it was a physiologic management of the third stage. 6% received 10 units of oxytocin, and this was most likely received intramuscular or IM. And another 6% received more than 20 units, and so this was likely treatment or prevention of high-risk postpartum hemorrhage. So again, our third aim was to look at the total dose of oxytocin received during labor. So this is stages 1, 2, and 3, and how that was linked to our lactation outcomes. And for every additional 10 units of synthetic oxytocin a participant received in labor, there was a 21% lower odds of any breast or human milk feeding at the postpartum visit. And there was a 17% lower odds of exclusive breastfeeding at the postpartum visit. And I want to highlight that in these models, we looked at epidural anesthesia, length of labor, and total length of exposure to synthetic oxytocin, and none of these were a significant predictor of our outcomes. So for our next aim, I wanted to look at how the Baby-Friendly Hospital Initiative might influence these relationships. And I had data on human milk feeding at discharge in a subset of 760 participants. Of those, 699 were doing any sort of breast or human milk feeding at discharge, and only 61 were formula feeding at discharge. So we had a really high breastfeeding initiation rate. I want to zero in on that 699 that received human milk at discharge. At their 2 to 8 week postpartum visit, 85% were still doing any breastfeeding, and 15% had switched to formula. And so in an attempt to account for infant feeding intent at discharge, we created a new variable to indicate human milk feeding cessation between discharge and the postpartum visit. And we use that as an outcome variable in the next model. And among participants doing any breastfeeding at discharge, those receiving synthetic oxytocin during stages 1 and 2 of labor were twice as likely to stop breastfeeding by the time of their 2 to 8 week postpartum visit. And this finding was influenced by the Baby-Friendly Hospital Initiative implementation, because this was true only for the pre-baby-friendly cohort. Those who received synthetic oxytocin in that cohort were 4 times as likely to stop breastfeeding by their postpartum visit. However, synthetic oxytocin exposure was not predictive of breastfeeding cessation in the post-baby-friendly cohort. So therefore, the 10 steps may be protective of lactation for those receiving synthetic oxytocin for labor induction or augmentation. So for this study, the take-homes are that exposure to higher doses of synthetic oxytocin in labor, stages 1 to 3, lowers the odds of any exclusive breastfeeding at 2 to 8 weeks postpartum. Exposure to any synthetic oxytocin for labor induction or augmentation increased the risk of early breastfeeding or human milk feeding cessation. And this effect was specific to the pre-baby friendly cohort, and that implementation of the 10 steps may be protective of lactation in this case. This was the largest study to date to examine synthetic oxytocin dosing in relation to lactation outcomes. Limitations include lack of data on infant feeding plans during the prenatal period, and also limited data on breastfeeding at discharge, which I plan to rectify. And also future directions are to do some work to determine what are the physiologic mechanisms by which synthetic oxytocin might be affecting lactation outcomes. So right now I'm doing a pilot study in the newborn clinic with the CTSC looking at oxytocin and oxytocin receptor levels in human milk, and to see if there's any association with when milk comes in and also like how much milk is made in those early days of breastfeeding. So take home overall is how we care for clients in the perinatal period does matter. And the Baby Friendly Hospital Initiative is a proven package of interventions to increase lactation, initiation, and duration, and it works in our diverse local community. The more our clients are exposed to the 10 steps, the more likely they are to feed human milk, and it may be protective when there are risk factors for breastfeeding cessation present. While the Baby Friendly Hospital Initiative focuses on prenatal and postpartum care practices, much less attention has been focused on how intrapartum care practices or practices during labor or birth might affect lactation. And so exposure to synthetic oxytocin is just one example of an intervention during that period that we could better understand in relation to the establishment of lactation. And if we increase our knowledge, this could inform shared decision-making with our clients and also lead to targeted lactation support for clients in the early postpartum period. So I'd be happy to take any questions. Thank you.
All right, so thank you for that presentation. If you have any questions, again, please raise your hand or put it in the chat and we'll be happy to direct them to our speaker. There we go, okay. So any questions? Mary, did you have a question? I can always count on you for a question.
Yeah, and I was so happy to give other people a chance, but I wanted to ask Dr. Cavilton about at the Baby Friendly Hospital at UNM, how hard was it to, I know that's not part of the study, but how hard did she find out it was to make all those steps and get everybody on board to do the Baby Friendly?
So full disclosure, I joined the practice at UNM the year they became designated. So I wasn't there for all the heavy lifting, but I can tell you they have a really strong Baby Friendly Hospital Initiative Committee, which I have sat on during my time with the practice. And it was a 3-4 year journey in order for them to go from the idea of wanting to become Baby Friendly certified to doing all the staff training, making sure that annual trainings are in place, really changing the culture, changing the documentation, really getting everybody on board to bring that designation into reality. And so it was a huge lift for all the providers and the nurses and the staff that were involved in that at the time. And so we're so grateful to them for the work that they've done. And we've been redesignated now. I think it was 2019, they did a repeat site visit because they do it every 5 years, and they redesignated us that year.
Okay, and Denise, did you have a question?
Yeah. I'm just curious, I may have missed this, but I was wondering why the breastfeeding rates are lower when the synthetic oxytocin is given. Is that because of the prolactin, levels of prolactin levels? I was just looking for the correlation.
Yeah, we think that's part of it. So we don't know for sure. That's part of my future questions. But the hypothesis is that really high levels, because synthetic oxytocin levels are much higher than the body naturally makes, we think it may lead to receptors being desensitized or actually being pulled away from the cell surface. So there's fewer receptors on the surface of cells. So they're less responsive to oxytocin. We also think it affects how the brain might release both oxytocin and prolactin. And so it might affect milk supply in that early postpartum period. Good question.
And the prolactin affects the infant's breastfeeding behaviors too, or did you say that?
Yeah, so we know that baby's probably getting exposed during labor through the placenta. And they have shown that in babies that were exposed, they show fewer feeding behaviors and are less likely to feed in that first hour. Yeah, we're not exactly sure what the oxytocin is doing to lead to that change in behavior, but it has been observed.
Okay, thank you.
And I believe, Lee, you have a question?
I was wondering what it would look like to make sure that things like the baby-friendly training are integrated into the College of Nursing curriculum. There were some units that I took last semester that I have taken the trainings as a volunteer doula through the Birth Companions program with Katie. So I understand the material, but I was surprised to see that there were several things being taught or parcels of information being offered that did not follow that, I guess, policy. And I was wondering if there was anything that I could do maybe to petition for that to be more in alignment with that, as not all will go on to practice at a baby-friendly hospital potentially.
That's a really good recommendation that it should be, integrated into all of our curriculum. And I know that there are definitely parts where it is, and I think it would probably be a goal for us to make sure it's well integrated throughout. Thank you for that recommendation.
So we do have a question, a couple questions in the chat. Do you know if there have been any studies related to maternal mental health related to the baby-friendly breastfeeding initiative? Anecdotally, I've heard about many mothers experiencing stress and increased depression and anxiety related to the strong emphasis on breastfeeding, especially for mothers who experience difficulty with breastfeeding. It seems like the resources are not available to provide all the 10 steps adequately in our current healthcare system here in New Mexico due to high nurse-patient ratios and short staffing.
Mm-hmm. It is a goal to have this become high priority in most of our hospitals, and it's something that the New Mexico Breastfeeding Task Force is actively working towards supporting, is helping all the hospitals become baby-friendly certified. But you raised an excellent point that we often think of human milk feeding or breastfeeding as a very natural thing and that it should be easy, and it's not always easy. And I want to fully recognize that reality. And it can be very stress-inducing at a time when a postpartum person has worked very hard and may not have had enough rest, and so there can be quite a few challenges. I think our goal with the Baby Friendly Hospital Initiative is to provide support, but not to increase stress levels. And I agree that there should be more research to see how those interventions affect the lactating parent in the early postpartum period.
And then our next one, actually, it's more of a comment than a question, but I'll read it. I was an IBCLC, Kathleen, I'm not a nurse, so I'm lost there, but that's okay. And staff at St. Vincent's, and we're trained in baby-friendly policies thanks to Molly Pestle in 1997. Loved it.
So glad to hear that.
Do we have other questions? While we have a small break in this, Dr. Ruach, there was a question just before we got off with you about sharing a list of studies that you presented. I will tell everybody on here, we are going to provide in a few minutes the email addresses for both of our presenters. So if you have additional questions, you can always reach out to them personally, and they are happy to answer your questions or provide you with their resources as well. Oh, and that just went in the chat. Thank you. Do we have other questions? Go ahead, Mary.
Who, if anybody, is studying what's going on in our state around the different hospitals on baby-friendly initiative?
Yeah, so I think I mentioned the New Mexico Breastfeeding Task Force. They're a statewide organization whose goal is to increase lactation success and outcomes across our state, and they're very actively engaged with hospitals all over the state to try and support practices that will improve lactation outcomes and supporting people on the journey. So they're the ones that are really the most knowledgeable with regard to the percent of hospitals that are designated in our state in particular. And if you want to reach out to me, I can get you that information.
Do we have any other questions? Okay, well, thank you, Dr. Cavilton. I appreciate your time and your expertise.